I'm just thrilled now to have some time that we can all spend together with Dr. Mindy Bixby. I'm sure many of you know her, and probably several of you are her patients. She's a movement disorder specialist, practices with Scripps Institute in La Jolla. We've also been talking about how she's working with telemedicine and telehealth. And we're just delighted to have you, Dr. Bixby. You're one of our most popular speakers.
Thank you so much.
And today we're going to do something a little different. We're not going to talk on just one topic. Dr. Bixby has 3 topics because these are kind of the more unusual or symptoms of Parkinson's that some of you may be experiencing. We're going to do 3 sections, one on shortness of breath, one on dry eyes, and one on temperature dysregulation. And after each topic, we'll stop and ask you all if you have any questions about that topic before we go on to the next one. So as you all know, or most of you probably do, the chat feature at the bottom of your screen allows you to type in questions, and we'll keep track of those for you and make sure Dr. Bixby hears them. And then additionally, you're all muted when Dr. Bixby is speaking. And what we'd like to do is go through the section and let her present the information, see if she hasn't answered whatever question you had. Then afterwards, we can do the chat and hear unmuted questions as well before we move to the next section. So Dr. Bixby, wonderful to see you. Thanks so much. And let's go for it.
Okay, let's do it. So I'm going to actually share my screen, everyone. And so we're going to start out that way. And then again, like we said, I'll ask you if you have any questions before I go on to the next section. Okay, so let's share my screen. Here we go. So today we're going to be talking about the lesser known symptoms of Parkinson's disease. And the first most important part about this is I want you to be very comfortable about what we're doing here. So our talk outline, we're going to talk about non-motor symptoms of Parkinson's disease, just a short snippet about that. And then we're going to go a little bit more in depth for shortness of breath, dry eyes, and temperature dysregulation that some of you may be experiencing or have experienced in the past. You may never have these symptoms, but again, it's important to actually address them, because if you are, then we need to go forward and see if perhaps it is part of Parkinson's disease or if it's a part of something else. So here we go, next. So this is an interesting slide, and I'm sorry it's a little busy, but it's really important to understand where we are in regard to the motor symptoms of Parkinson's and the non-motor symptoms. And so when you look above, this is exactly what a lot of people are experiencing. People are noticing that you may have some tremor, or that when you walk you're a little stiff, or when you move you're a little bit slower, or you may not feel safe on your feet, or you're having difficulty with maybe shuffling or breathing. However, those are the symptoms that you can see. Like you can see this iceberg. And so when you look at the iceberg, that's what you see, but there's maybe a lot of things underneath it that you may be experiencing that you may not know that it's associated with Parkinson's disease. Let's go through some of them. So some people can have fatigue, which may be your #1 symptom. Pain, apathy, like not really wanting to go and do anything like you used to like to do. Like you used to love to play golf, and you don't want to do that.
No motivation is apathy.
Okay. Shortness of breath, or which we'll be talking about today. That's why it's highlighted in yellow. Dysphagia, like difficulty swallowing. Constipation is one of the #1 symptoms you can have way before you ever have Parkinson's symptoms, motor symptoms. Urinary changes like frequency, urgency, gotta go as soon as you can. Sleep dysfunction, like not sleeping as well as you used to, or sleeping shorter or longer distant times, or even to the point where you're acting out in your dreams and talking in your sleep. Temperature fluctuations, which we're going to be talking about today in depth. Orthostatic hypertension, when your body is, you stand up and you start to feel dizzy and lightheaded, and you may have low blood pressure as a cause of this not really having an autonomic kick into blood pressure, which we'll talk a little bit about as well. Depression, anxiety can be some issues that you may be experiencing. Cognitive changes, some people may have hallucinations, visual and auditory. And some people may have drooling or excessive saliva or low tone of voice. And this is not at all encompassing list, but this is actually some things that I see more often than not. And so today we're going to be talking about dry eyes, temperature fluctuations, shortness of breath, but I'm sure we'll be addressing all the other issues that you see on the screen. So the first topic will be shortness of breath. Let's talk a little bit more about it. The other name of it is called dyspnea, which ultimately can be caused from so many different things, whether it be respiratory conditions, breathing passages in the lungs, circulatory conditions. Some people can have congestive heart failure and the pump's not working as well. So you're not getting that oxygen through the system as well. Other conditions can be anemia, if you have like your blood pressure or your blood is not circulating enough red blood cells to actually create oxygen to be able to go to your tissues and your vessels and your body. You can have shortness of breath. Some high fevers can create that because you have this inflammatory response, creating a fight or flight kind of feeling where it allows you to have shortness of breath. Some people can have allergic reactions, of course, when you're eating stuff or things that actually can create a smaller, narrowing breathing apparatus. And then chronic conditions, which we'll talk about today. This is the evaluation that you're looking at on the right side of the screen is basically saying what's happening to you is shortness of breath. We won't go too much into that right now. So the biggest question we have, of course, and that's why we're here, is does Parkinson's disease make you short of breath? So there was a great study that was done in 2018 where there was a meta-analysis evaluating if people have shortness of breath with Parkinson's disease. It was found from this trial, which was about 12,000 people, which they evaluated, they noticed that there's about 35.8% of people that report shortness of breath on exertion. They also noticed that 17.9% of patients have a cough that contributes to shortness of breath, and 13% are reporting increased sputum production, which can cause a shortness of breath as well. So what are the common signs and symptoms? So shortness of breath is one, but you may actually notice that you're having more coughing or difficulty getting the cough out, or again, shortness of breath. Sometimes pneumonia can be one of the respiratory dysfunction. Aspiration, when you eat something and it goes down the wrong tube, can go around, it's supposed to go down the stomach tube, but it's actually going into the lungs, creating a shortness of breath. Reduced exercise intolerance, like you're working out, you're doing great, and all of a sudden you get shortness of breath. And why is that happening? Is it Parkinson related? Does it have to do with the system in itself? It has to do with the lungs, or the cardiac issues? And that's why we have to get down to the nitty gritty and find out what it really truly is. So people have speech difficulties and hypophonia, low tone of voice, and they're just not getting the oxygen that they need to actually make that voice heard. Sleep disorder breathing, which again can be sleep apnea or other causes, and sometimes people have to put a couple pillows behind them just to be able to breathe well when they sleep flat. And also excessive daytime somnolence, as you can see on the right lower picture. That's actually really common when you have shortness of breath. You're always working against the system or working against a barrier because you can't get as much oxygen inside the system to actually feel refreshed and feel good. And so those are some of the common signs and symptoms. So what is a possible mechanism of respiratory dysfunction in Parkinson's disease? Well, there's several different places. So that's why we have to really get down to it and understand it. So sometimes you can have restrictive changes inside the lungs. Ultimately, there's these tiny little muscles that actually are right along the rib cages, which are intercostal muscles. When those are not expanding and opening up, you can't open up that rib cage to get enough oxygen inside the lungs to feel refreshed and feel like you actually have a nice good breath. Upper airway obstruction, sometimes saliva, food stuff, and sometimes the anatomical of the tube that allows you to actually breathe in air and out air, with whether it be dystonia, with muscles being really tight, or the mechanisms of basically what's happening inside that system are narrowed and not allowing you to get the breath that you need to have to actually allow you to feel good and not feel short of breath. Some people, this is one of the most important things we want to talk about, is response to medication. You can have shortness of breath with a wearing off evaluation. So imagine this. You are breathing fine, everything's wonderful, and all of a sudden, bam, you start to notice, wow, I'm getting short of breath and more short of breath and more short of breath. can it be because your medications are wearing off? Because remember, dopamine does a lot of things. What it does do is allow your muscles to actually not be so stiff. And so like we talked about the physiological restrictive changes of shortness of breath, if those muscles are really tight around the intercostals and the diaphragm's really tight, you're going to have difficulties when you're wearing off because the dopamine allows you to have a little bit more flexibility in your muscles. Sometimes people can have it actually when they first take their medication. Again, we've been looking at all these different types of medications, but dopamine replacement medications are the most important thing that we're talking about today. And so you can experience almost something called turning on when you take your medication and you kick in, start to feel like it's working, and you get this really weird difficulty breathing. And when that happens, it's called respiratory dyskinesia. So we know that dyskinesias are the movements that you can experience when you have an overabundance of dopamine inside the brain. That also can happen with the respiratory system, where ultimately it's just not coordinating. It's not doing as well together. The synchronicity that you have when you breathe is important. With your diaphragm, intercostal muscles, and how well your breath is opening in and out and allowing it to do this. And so respiratory dyskinesia, basically that system is not perfectly aligned and you can have shortness of breath feeling. Anxiety is really important to talk about because twofold. One, you can start having shortness of breath as an anatomical reason, but when you start to get short of breath, all of us would feel a little anxious for that, like you're gasping for air, which would create a twofold increase of shortness of breath because if you're anxious, it creates this almost like a panicky feeling, and ultimately you can almost feel like you're actually losing more and more breath. And that's when we have to find a way to actually calm everything down, get to a place where you're feeling better, and the shortness of breath will improve. Some people have that, again, like we talked about aspiration pneumonia. You have to see how is your swallow apparatus doing. I mean, you may not be choking on foods, or you may be coughing a little bit when you eat, drink water, or eat foods. We really have to look at that as a possibility as well. Because what if some of that food stuff goes down into your lungs? What happens? Well, sometimes it can create a rhinitis or infection. When that food stuff is there, it's foreign, so it can create something that is an inflammatory response and ultimately creates some type of bacterial or viral pneumonia. So we have to make sure that always your swallowing apparatus is working well. That's why I always ask that question. Hey, how's your saliva production? Are you drooling? Are you coughing when you're eating? And how's the shortness of breath? Are you feeling pretty good when you're walking out, working out? Because working out is, again, really, really, really important for Parkinson's disease. But if you can't breathe well, it's hard for you to get out there and do stuff. So it's always important to actually see what's happening to you, when is the mechanism happening to you, and if you can figure it out a little bit more, let's go into a journal mechanism to see, hey, is it happening daily? Is it right around my medications? Is it happening when I'm eating foods? And kind of understand kind of what's happening in the system throughout the day, and maybe get to the culprit of why it's happening. So how do we manage this? And I think we talked a little bit about this a couple minutes ago. So a management of respiratory issues. So there's tons and tons and tons of information on this for us as practitioners and doctors, and also to have you have the best quality of life by understanding what can be happening in your system. There's tons of differential diagnoses and dyspnea in regard to neurological causes, but there's all these other things in regard to the whole system on how well it's working for you. So we always have to look at all aspects of it. The first thing is medical history. Do you have anything that could be creating this shortness of breath outside of Parkinson's disease? We have to make sure we look at that, or we'd be failing in regard to helping you. And so we have to look at all those aspects. Second is differential diagnosis. What we talked about before, all the possibilities. How is your lungs working? Are you anemic? Are you feeling, is your heart pumping correctly? Is your body actually, is something else happening? And then I always ask for a shortness of breath journal. I mean, I know some of you may know me, and I'm really big about, I can't be in your pocket all day long. I would love to, but I can't. And so if I could find a way to actually journal it so I can look at it with you and say, oh my goodness, this is really good telltale signs of why this is happening to me. And a journal is always extremely important, because then it allows me and you to understand, wow, this is when it's happening. Maybe it's because of medications or other reasons. So that basically dictates how we would treat shortness of breath. hey, if it's a wearing off symptom, we change the way you're taking medications. Is it something to do with the respiratory system? Then we have to do an evaluation with a pulmonologist and say, hey, is there something going on regarding your breathing apparatuses? Is it a heart thing? If we kind of understand more what's happening and kind of what the triggers are, then we can actually move forward and figure out what the reason is and help you and manage it and make you feel better. Okay. So that is the last part of this part of the talk. And so I want to make sure that we go through each section and answer the questions based on what we just talked about so that we can help you through it. And you don't forget your questions. And then basically, if I need to go back to some of the slides, I can. So is there any questions on shortness of breath today?
Okay, Dr. Bixby, we've got a few from the chat. And one of the people asked us, says her husband has shortness of breath while he's sitting, and his neurologist says it's anxiety related. The question is, how can he alleviate that feeling?
Great. And so if it's anxiety related, we have to figure out what is making him anxious. So if we can figure that out, if that's truly the reason. So the question is it truly anxiety or is it a wearing off symptom? And so that said, your husband may be short of breath for a lot of different reasons. Sometimes it's positional. If you're short of breath when you're sitting or when you're laying down, and you're not short of breath when you stand up, is that something that has to do with basically a little bit more stress on the lungs and not allowing you to actually breathe well? If you notice there's other symptoms of anxiety, like some people look anxious, or they're talking a little bit more pressurized, or they look like they're having a really big difficult time outside the box, and there's nothing really creating that anxiety. It's questionable if it's absolutely anxiety or if it's a mixture of both. Parkinsonian related, which dopamine delivery may be lower at that point, or is it more that there's things happening? For instance, the COVID-19. All of us are going through a little bit of change in regard to how we take care of everyday moments. And so that could be anxiety ridden for any of us. And please give yourself some peace with that and give yourself a little bit of an opportunity to actually say that, hey, everybody's going through this. But that said, if it's anxiety, then sometimes you actually get treated for anxiety, which could be medications or basically figuring out how to get out of that situation so you feel better.
Okay. Well, thank you. I wanted, before we go on, we've got a couple more questions for you, but I've had a couple comments that people are not hearing you as clearly as they would like. And there was a suggestion, maybe you could sit nearer to the mic or maybe reposition a little bit. We can, it sounds like some people can hear you better than others, and I don't know if it's on your end or what.
I don't know. See, I'm going to turn that up. That's your turning up. So I'm not, see, where is the mic's right here. It's actually on the computer itself.
Okay.
And so I can get really close to it like this, if that's okay. Sorry, it's on my face. But is this better?
Yeah, that I think is a little bit better. I'm seeing some nods, so that works. So
okay.
We'll just go with your close-up. You've got a good smile.
Okay, thank you.
You ready for another question?
I
a question about respiratory issues and COVID-19. Can you comment and discuss that?
Absolutely. So COVID-19, one of the main symptoms of COVID-19 is shortness of breath and having real difficult time breathing. Why does that happen? So the virus actually hits your respiratory systems and creates an inability for your lung cells to expand. When that happens, it ultimately causes an inflammatory response and sometimes to a place where you can't get to a good breath in. So again, if you've had shortness of breath in the past, it's less likely being created from COVID-19. I understand absolutely. All of us are like, how's my breathing? Am I okay? Because a lot of us don't have very many symptoms if we have the COVID-19. But shortness of breath is actually one of the #1 things that people notice. But you also have fever attached to it, significant fatigue. Some people have difficulty with bowel programs, diarrhea, and things like this. So ultimately, what I would suggest, if you're having some shortness of breath that's a little bit different or something that you've never had, I always ask you to please check see if you have a fever, because that's one of the number one things that we're doing at Scripps. Even people that have a fever that would be coming in to see me, which again is very little. We only have 1 day of true clinic at this point. We mostly have virtual. You have to make sure you don't have fevers. And so if shortness of breath is happening and you're also having some fevers, and there's other things that are in your breathing apparatus, your ability to breathe is getting worse, you do need to see a doctor. And so ultimately, yes, this is one of the number one symptoms that people are experiencing with COVID-19. However, it could be very likely other reasons for this. So we have to basically evaluate you, okay?
Okay. Another comment, someone said they were, when they seem to run out of breath when speaking, but not when exercising.
Yes, and so it depends on what you're doing. So where's your posture? How's your posture when you're speaking? And ultimately, is it a different way of, because when you're actually exercising, are you talking is the question. So if you're running, you know, there's like this nice one speed that if you run when you talk and you walk, or you talk and you run, or you talk and you're on the treadmill, there's a certain level of blood pressure and pulse and everything that's happening to you that creates a certain amount that you, if it's a higher level of intensity, you tend to have a little bit difficult time talking. So when it comes to not exercising or being in a stationary space and having difficulty, we have to figure out if we have to start doing some breathing exercises in regard to where you are and how your stance is and how well your posture is, because all of those are important to how well your breath is going to come in.
Okay, just to let you know, we are getting some good feedback on you being closer to your speaker.
Okay, thank you. I'm so glad.
Then we had a comment that someone for the last 4 years smells smoke sometimes.
Okay, so if smoke or different smells. So when you have Parkinson's disease, what's happening sometimes 10 years before you ever have any motor symptoms, you can have change in your nasal abilities to smell. And a lot of times people have lack of smell, but sometimes you can actually start smelling things that are totally different than are surrounding you. And it's literally, you're just getting this feedback to the brain of the sensory systems that is inaccurate. And that can happen with dopamine deficiency. And so it's a rare thing. And usually it's smoke or burnt tires. I can't explain why it's that smell, but ultimately it's usually that smell of smokiness or burnt smell that is concerning for the patient, the person. I mean, I wish it was raspberries. I don't even know if they have smell on the raspberries, but things that are actually lovely to smell, like flowers perhaps. But it is an uncommon symptom, but it is something that does happen, can happen with Parkinson's.
Okay, that's great. Thank you. Rachel, do we have any people with their hands up or?
Not that I see, although because it's not
well, I'm
full screen of people.
Probably need to move on to the second topic of dry eyes.
Okay, let's do it. Are we all ready?
Yeah.
Okay. Trying to get closer, but you'll only see my screen, so it's probably better. Here we go. So dry eyes in Parkinson's disease. And so I need to give you a little bit of background of anatomy of the eyes themselves. So if you can imagine the glass area part of your eye, which is your cornea, and all throughout the area where the white part of the eye is, there's something called a tear film that is really important to make sure you have enough lubrication in the eyes, okay? So if you look on that screen on the right-hand side, you'll see that there's 3 different layers. One's an oil layer, one's a water area, and one's a mucus area. And so all 3 of these are important to have a nice hydrated eye. If one of them gets less, ultimately you have difficulty, and you can feel dry eyes and difficulty with other things, which we'll talk about in a minute. So what happens, tears are spread through the tear film when you blink your eyes, okay? And the average blink rate of an eye is about 10 blinks per minute. In Parkinson's, the blink rate is decreased. Sometimes it's decreased considerably, and that's when people have that Parkinson's stare, because they don't blink as much as they used to. When that happens, it decreases the ability for you to lubricate your eyes. And so sometimes I ask, please close your eyes and make it more of something that you're doing on a regular basis, and that may help you, which we'll talk about treatments in a minute. But if it's already known that that tear film that you see there decreases in size and abilities when you age. So your eyes are nice and fresh at 10, 20, 30 years old, and as we get older, they get less and less ability to actually keep that hydration well. And so the other thing is possible medications. So some of the medications that you're on possibly for Parkinson's disease can create a dry eye feeling. And that's another thing we'll talk about in just a minute. So all these are leading to dry eyes. So what happens when you have dry eyes? Let me see what the next slide is. The symptoms of dry eyes are several. So first of all, decreased vision. Oh my goodness, what do I mean by that? So if you have dry eyes, and remember those 3 layers, if the light is coming through the eye and giving you an image on the back of your eye, if it's not allowing you to disperse the light that's coming in, you're gonna get a blurred or decreased ability to see something. Next is, as you can see on this lovely eye, there's burning eyes, because what lubrication also does is create an ability for anything that's a debris type thing that we walk around and there's stuff in the air, keep it away so you don't have that feeling of irritation. Also, stinging eye is another thing you may be experiencing, or red eye like you see on the screen. Watery eyes, interesting enough, people go, I feel really dry, but I'm leaking all the time. I constantly wipe my eyes. And you can have watery eyes and still not have enough of lubrication. And we'll talk about that a little bit more in a minute. You could also have the gritty feeling in the eyes, like almost like there's something underneath the lid, because they're so dry that what happens is the cornea itself, the clear part of your eye that you see here, if it gets too dry, what happens is it can create little bumps, like almost like little scratches on that eye. And when that happens, the lid will go down and you can actually feel like there's some grit or some sand underneath there, which is not comfortable at all. And then double vision is also common, which again, somebody you're like, oh my goodness, is that the reason why I'm having double vision? And we'll talk a little bit more about possibilities and what other things it could be outside of dry eyes. So how do we evaluate you if you have dry eyes? So first and foremost, again, you're telling us you're feeling this, and so we need to move forward and see why. So there's several diagnostic tests that you can do with a ophthalmologist, and then there's also a neuro-ophthalmologist. A neuro-ophthalmologist is one that actually specializes in neurological causes of eye disease, okay, or eye problems, which again, we have a couple in San Diego and several in Orange County. And again, I'm not sure where you are right now, but neuro-ophthalmologists actually can help us a little bit more, because ophthalmologists look only at the eye and the optic nerve. The neuro-ophthalmologist looks all the way through into the brain as well. So they're both very wonderful specialists, but depending on what you need, it depends on what the referral will be. So they do a complete eye exam with many different testing modalities. Sometimes they put this dye in there so they can actually really see it. Something called a slit lamp. I think most of you have seen it, where they put the eye, they go back and forth and make sure everything's good. They're evaluating the integrity of the cornea itself, the outside of the eye, when it looks like a contact lens. And they also look to make sure there's not any scars or anything else that's going on with that. They also, they talk about how you would treat it. And so there's several treatments for this, depending on what you're experiencing. So again, as you can see on the bottom, there's lubrication. Lubricating you with artificial tears, which we'll talk a little bit more about it too. Increased water intake will always help you. No matter what's going on in your life, if you're not hydrated, you're not going to feel as good. Fatigue, dry eyes, ability to actually move and feel good, and ultimately have your brain work as best as it can. But water, okay? Use of artificial tears, there's several different aspects of artificial tears. Again, they have a little bit of salt in them, a little bit different. It's the pH that your body's used to having. And so that's why you would use those. If that's not effective, they consider doing something called plugs and tear ducts. So why would you put a plug in a tear duct? So what it's doing, it's actually stopping the ability for you to lose those tears And so it blocks it just a bit so that you're actually lubricating it longer, so because it stops the tears themselves from leaving your eyes. And sometimes it's quite effective. If that's not helpful, sometimes people consider putting fish oil, which again, don't do this alone. You have to have an evaluation of ophthalmologist and they'll tell you how to do this. But some people actually have put an oil film along in their eyes so that they're actually getting a little bit more lubrication. Remember the 3 layers which we're looking at here, the mucus layer and the oily layer. That oily layer is on the outside. So if you were actually increasing that oil ability, you may have a better opportunity to have less dry eyes. Restasis is another one, and then also steroid eye drops is another opportunity too. And so those are some things that you actually can do to actually help with dry eyes. And again, some people have to go a little bit more and do a mechanical change. And also look at your medications. Is there a medication, or are there several medications that are on board that are making you dry, whether it be dry mouth, dry eyes, constipation, and other things that can be created if you have too dry of a system. So I think that's all for dry eyes. And so any questions?
Do you want to take some questions now?
So this is the last bit of dry eyes. So the next one is the temperature regulation. So if anybody has any questions for dry eyes, I'd love to answer them.
I think Ken Schiff would like to ask his question about his dry eyes. If you want to unmute yourself, Ken. Are you able to?
If not, we can read it.
Yes. Okay, well, he was diagnosed with dry eye and had punctual plugs inserted several years ago before tremors showed up, and was diagnosed with PD. Do you think that dry eyes could have been an early symptom?
Absolutely. Because what happens is it's very possible that your blink rate was less. And so as the blink rate was less, like we talked about, you have less ability to keep those eyes nice and happy. And so it's very possible that's the case. Even though they put the plugs in the tear ducts, it most likely helped you. But perhaps if you would have had dopamine on board then, you may have had less dry eye at that point, but it's hard to say.
Okay. We have one here, and I relate to this personally because I had cataract surgery, and he's saying that when he drives, he sees halos around lights and sometimes double vision. Can you comment?
Sure. So I guess that can come from a lot of different things, just like you said. And so depending on what's happening in regard to, is it dark outside, you know, all the differences in what you need. Like if it's really dark outside, you're really relying on your eyes without a whole lot of light. So there's a lot of muscles and everything else that's being coordinated to be able to actually see dark. But if you're just talking about driving period, double vision's interesting because there's a lot of possibilities when it comes to Parkinson's why people have double vision. The first one, again, we'll talk about dry eyes. So if you have dry eyes, what happens is ultimately your brain is trying to regulate what it's seeing. So it always wants to try to create one image on your fovea, which is the back of your eye, to give you a clear understanding of the natural occurrence of what's happening in your world. And so if you're getting too much feedback with dry eyes because you're not getting that lovely light to go in and give you a good image of what's happening, you can have two separate images on your fovea, creating a double vision. The other things that can happen is that, again, remember with Parkinson's, you can have stiff muscles. And so if you have stiff muscles in your eyes, which basically there's 6 muscles that are coordinating your eyes to go back and forth and up and down and around. If those muscles are tight, and it just happens to be one of the muscles that is tight, if it's pulling this way all the time, you're not getting the nice convergence and getting one image on your fovea, which ultimately can create a double vision. A lot of times when that happens, your ophthalmologist and your neuro-ophthalmologist will give you prisms, which basically cut the light the right way and allow you to actually have one vision on your fovea. So it depends. And so with driving, why is that happening? And if you can create a corrective of opportunity. And so we have to actually have you see a neuro-ophthalmologist because you're having twofold things when you're driving, and why is that happening? And ultimately, because you have Parkinson's, I would like to have you go to neuro-ophthalmology to be evaluated.
Okay, here's another one. People, does dry eyes make you more susceptible to COVID-19?
No.
Oh, good. That's right to the point. Um, if my dry eye is due to PD with the treatments, drops, plugs, fish oil, be different when it's due to PD than just dry eye. So is there a separate treatment for dry eye that's PD related, or is
it can, normally no. Normally the answer would be absolutely no. If you're having something that you're taking on a medication wise for Parkinson's disease, and we can change it for you to feel better and still have a good benefit in taking care of your Parkinson's symptoms without having the dry eye, that's always an option. So some of the medications that are on board for Parkinson's disease tend to cause more dry eye than others. And so just evaluating what you're on and evaluating, okay, maybe we can try this and maybe still get a benefit for your Parkinson's symptoms without having the dry eye. So that's something that you have to talk to your doctor about.
okay? Well, I think we've come to the end of our questions about dry eyes. Do you want to move on then to temperature regulation?
Let's do it. So this one's important because we're going to talk about a couple things. And so just so that I may go into a little bit more of just the temperature, more than temperature regulation, dysregulation, just because I just want you to understand a little bit more what's happening in the autonomic nervous system. And so the autonomic nervous system, there's three nervous systems that create the whole nervous system. There's the central nervous system, which is your brain and your spinal cord. The second nervous system is the peripheral nervous system, which is basically all the nerves that come out as soon as it leaves your brain or your spinal cord. That's your peripheral nervous system. Okay, that's you move your hands and do those things, and you sense things, and it goes up to the brain and tells you. Because it's basically like a conduit or a directional thing. The third one, which I really want you to understand, because it's like a little bit harder to like grasp, is the autonomic nervous system. Autonomic means automatic. And so you breathe, you may think about it every once in a while, but you don't think about it 24/7. It's something that's happening and allowing you to have it without having to actually control it, okay? And so you need to go to the bathroom. You don't say, okay, I'm gonna go to the bathroom, and it's not necessarily this automatic thing that's happening. Your kidneys have to work, and your uterus have to work, and your bladder has to work, and it basically tells you at the end of the moment when it's ready to go to the bathroom, to go to the bathroom. Or your heart rate. You can have a little bit of control when you're running upstairs, you know it's gonna go higher, or you calm down, it goes lower. But usually you don't have control of your pulse or your heart rate. If you did, you'd have to think about it all the time, and you couldn't sleep, and things would be hard. Also with your blood pressure and your flow, your circulation, that's also autonomic. So if you look on the screen, we talk about parasympathetic and sympathetic nervous system. This is your autonomic nervous system. So your parasympathetics, what happens with them being engaged is when you're just resting and you're digesting. And so those are the things when you're resting, when what's happening in your system when this happens. And so it's correlated and coordinated, all together to make sure that your body's ready to ruminate, take in that food and digest it, and also for rest and sleep. The parasympathetic system is kicked in for that. When you're running from a bear, or you're fight or flighting, or you're having a panic attack, or you're anxious, or anything's happening to you where you have to protect yourself, these are the systems that kick in, which is called the sympathetic nervous system. You know, your pupils dilate, you have increased saliva, your heart rate's running, you constrict your blood vessels, you dilate bronchioles, you don't allow you to ruminate, so you're not trying to digest food, you're trying to run from a bear idea, okay? And so these things are all automatic or of what we deal with when we are dealing with our system as we wake up and when we're sleeping. And so some of these are coordinated with regard to understanding what is happening in your space surrounding you and environment. If we didn't have these, we wouldn't be able to survive. So sometimes the coordination or the connections are off, meaning that, okay, I'm not working out right now, but I'm sweating a lot. Or I am not in a blizzard, but I'm freezing right now. And normally our system tries to figure out how to make temperature regulation just perfect so we're always very, very comfortable, okay? And so those are the things we need to talk about today. So Parkinson's disease, there are changes in the system, and there's a big big amount of changes in the autonomic nervous system all the way through when it comes to something called Parkinsonism from multisystem atrophy. And so we'll talk more about Parkinson's disease, but it is very, very common and more common with multisystem atrophy. Okay, so next slide. So temperature dysregulation in Parkinson's disease. So again, we talk about two different systems, cold and hot. So you may have heat intolerance or cold intolerance, or you may be sweating a lot, which is called hyperhidrosis, or, and it's maybe be one part of your body like, oh my goodness, my head sweats a lot when this happens, or I don't know why this happens, or my hands are sweaty and I don't understand, or it may be the whole body that's being coordinated and it's all sweaty and it comes and goes, or it's happening all the time. So that kind of helps us understand if it's something else outside the box, which could be thyroid difficulties, uncontrolled hypertension, high blood pressure. Long-term drinking can create this. Diabetes, because your body's just trying to deal with what's going on. So again, the fight or flight possibility always happens. Why? Because your sugars are not in control, or your blood pressure is too high, or you have an autoimmune disease, which can be associated with this. Okay, so some people just don't have straight Parkinson's disease, and we have to look at those other possibilities to make sure everything is nice in a good place. Again, I need to talk about the possibility of wearing off. So wearing off, if you're wearing off your medications, a lot of people mid-level, when you start to have the mid-place of the disease, you may have this weird wearing off, like you don't start to have more tremor or more stiffness or more slowness. You actually feel like a sweating moment coming on, or you get really, 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 really cold. And that may be your trigger to know that you have to have more medication on board or change the dosing of your medication so it actually improves. And so, let's see what else I have. So, temperature dysregulation in Parkinson's disease. So, sweating can occur with wearing off, like we talked about, or being cold. You also can actually have it, which you talked about as well with other medications, something called acetylcholine. So, there's acetylcholine. It's called dry as a bone, which again is the dry eyes we talked about earlier. But you also can have excessive sweating or be really, really, really cold with your medication being kicked in. So levodopa has an acetylcholine type way at times, not always, but people can experience the side effect of sweating or being extremely cold when they're wearing off because their body doesn't know what to do, or when you're excessively too high on the dose and this is created. And so again, journal. It really does help understand a little bit more what's going on. So as you can see on the right side of the slide, some people have a typical day like this. The medication kicks in, it does great, and then you alleviate it, and then you start noticing your symptoms beginning to return. If you notice perhaps that you're having sweating or being extremely cold right around the time you normally are about to take your next pill, it may be the fact that your dopamine levels are lower and you need more help. Some people actually experience it when their medication kicks in and they start to sweat. And again, what's happening? Are they sweating because they're sweating, or is it because their muscles are starting to move a lot, which is called dyskinesias? And so you have to look at what is happening with you individually to understand if you're having this symptom, why is it happening? And it really helps with the journal because you get an idea. Oh my goodness, it happens every day when I wake up in the morning. Okay, what's happening when you wake up in the morning? Or it's happening in the middle of the night, excessive sweating. Why is that happening? Because a lot of times you take your medication right before you go to bed, and then you wake up in the middle of the night because you're off. And that sweating may be your first symptom that you have when you are wearing off. So how would you change this? So treatments usually are changing the timing of medication. If it's truly looking at the journal saying, oh my goodness, and it's so nice because it's nice gestalt. I love journals because it really helps me understand what's going on in your life when I'm not seeing you in the office. So if you notice, wow, there's like these peaks and troughs of why this happens, and it's very possibly coming from this. Again, it can be hormonal, absolutely, especially as females. But that said, if there's no clear correlation with that, then we have to look at other reasons, and possibly it is medication-induced or Parkinson's disease induced itself, because sometimes Parkinson's disease can cause autonomic dysregulation, meaning that your body is not working at its utmost possible opportunity in the autonomic nervous system. That's why orthostatic hypotension happens, which means when you stand up, your blood pressure drops. It really, truly should be going up, because again, remember, you stand up, and what's happening is you're working against the Earth's gravity. So you need something as a mechanism inside your body that will keep the blood pressure nice and happy and keep that oxygen going to the brain. So some people don't have that mechanism to squeeze those vessels and allow you to get the blood pressure. Again, this is your autonomic nervous system. And if that's not happening, we have to discuss that. You have dizziness and low blood pressure and feel like you're going to pass out. That's another autonomic regulation or dysregulation, which is orthostatic hypotension. Okay? And so those are the things you have to consider when you're having excessive sweating or excessive cold. It may be part of the Parkinson's disease itself, or maybe a medication-induced decrease or increase. So as we talked about other things, so interesting enough, we talked about something that's called hyperhidrosis. Hyperhidrosis is basically the coined term for excessive sweating. I have patients that only have it in their hands, and it drives them crazy. And so what I do is there's actually an option to get Botox in your hands. I know that sounds really weird. You're gonna have really beautiful hands. But basically what they do, we do injections through the hands, and then the sweating doesn't come back for 4 to 6 months. And so if there's a place that's very like specific that you're having it and not everywhere, like underneath the armpits, in the hands, in the arm, in the feet, or in the head, we can consider doing an injection for those, and it actually works beautifully, and it lasts for up to 6 months. So that's a possibility as well, if it's only in one location. If it's all over, I can't really do that because that wouldn't be warranted. And so the most important thing, then we'll go into, actually let's go back here and I'll talk about that in just a minute. Is there questions about temperature dysregulation?
Well, we have one comment as of just now asking you to get a little bit closer to the mic.
Okay.
So if you can
Sorry about
do
that.
that again, that would be great. And then regarding the eyes, somebody did have a question before that they're finding that their pressure behind their right eye, that sometimes they have to close it in order for them to then be able to focus. They do have dry eyes, and is that PD related, that pressure?
So if it's only one eye, it tends to be more of an ophthalmology evaluation soon, okay? Because usually when it comes to Parkinson's, it's diffuse. It's everywhere, you know? And so it's more, again, the dry eyes can be contributing to it, but usually when it's only one eye globe, you need to be evaluated anatomically and see if something else is going on.
And someone commented, Bev did, that it says like her temperature dysregulation happens as soon as she lays down to sleep and every time she rolls from one side to the other, but it only lasts a minute.
Okay. So you have to see if that's hormonal or if it has to do with something with your blood pressure as well, because you're lying flat. Are you having too high of blood pressure when you lay down? And then you basically wake up the beast when you move from one side to another. And so you have to kind of, if you can do a blood pressure evaluation when you lay down and see if that's happening, because sometimes, again, the autonomic nervous system is just trying to tell you something's up in the nicest way. And some people have excessive sweating when they lay down. The other question I have is, what's your timing of your medication, of the carbidopa or whatever you're on? Are you taking it right before you go to bed and then you lay down flat? Are you having what we talked about before, where you're having this excess of dopamine on board and creating a sweaty moment? Or is it you haven't taken enough when you're halfway through the night and you're having that excess evaluation in regard to the sweating moments? And so you kind of have to look at the journal again and see what is happening, and is it different every single night, or is it happening all the time, and then see if you actually can see if there's a correlation between the medications. Again, it could be just that your body is going into its restful state, and then everything's kind of just calming down, and you may experience the sweating that some people have. But you have to see, and again, I just want to let you guys all know that from my patient's evaluation, even though you may be experiencing this, usually over time it goes away. And I can't explain to you why it goes away, but you go through maybe even sometimes a year or so of this excessive sweating, and then it just doesn't do it anymore. And I can't explain it, and there's not actually any literature I would give it to you of why it stops all of a sudden and what changes in you. But that said, just so you know, it could be a temporary thing that's happening to you, okay?
Okay, and Bev commented back, she has low blood pressure and doesn't take dopamine meds.
Okay, so when you have a low blood pressure, you're basically going through a fight or flight moment. So when your blood pressure drops, it doesn't know what to do. So it has to do something, and it can't get your blood pressure high, so all the other autonomic systems may kick in. It's almost like, so again, low blood pressure is interesting. So it can go up and down. It's so used to going so low, and then when you lay flat, it goes up higher. So your body's so used to being low, and then when you lay flat, you may have a higher blood pressure, which again, that's why we evaluate orthostatic hypotension. We evaluate supine, sitting up, and standing up to see basically what's happening. You can have a 10 to 15 point drop when you stand, but you also can have a 15 point drop when you lie down. And so if your body's not used to that and you lay down, your body has to like calibrate of what it's like to have that blood pressure, and that may be an issue. So you may want to check your blood pressure when you're lying down and see if that's a difference.
Okay, that's a great answer. Well, it certainly sounds like with all of these, that journal is the clue to figuring out a lot of what's going on.
Yes. Yeah, you got it. You won.
Yes, absolutely. You know, just knowing what meds you're taking when and what's happening as you do it is a really revealing kind of thing to have on hand.
I think so too, and it helps so much with I mean, you only have about 45 minutes or so with your doctor. If we can have this type of information, we can really help you out, but so much easier because we kind of see where you've been through and what are the main things you really want to address that day. So as you can see, every single one of them talks about journaling your symptoms. It allows us to understand and help you move through your life the best we possibly can with what the information we have at hand, you know. So that's what I believe in. Yeah.
I wanted to ask you one question related to anxiety.
Sure.
Is anxiety and that feeling of shortness of breath and the constriction in the throat and, you know, the shallow breathing and all, it's a response to a fear of something in the future for anxiety.
Yeah.
But the other question I have is, can that feeling be caused physically? Your body's doing this physically and your brain's trying to make sense of it, so it kind of tries to figure out what it should be scared of.
Yes, absolutely. So it's literally like a catch-22. What came first? Shortness of breath or anxiety? I mean, I have so many patients that I take care of with panic attacks with Parkinson's and shortness of breath. And so we have to find a way, and we do behavioral modifications so we can figure out what is it. Is it really truly the shortness of breath, physiological, or is it psychological, where your body is like, okay, I'm in a scared place. What do? I'm going to actually act like I'm running from a bear, which is the shortness of breath. I'm trying to get there. So yes, thank you for saying it's very true.
So kind of deciding that, especially say with a care partner, someone asking, you know, you may say, well, what's making you feel anxious? But it might also be just as beneficial to say, let's take some deep breaths and just get someone to relax.
I'm a huge fan of mindfulness. I'm a huge fan of breathing. I mean, all of us need it at this time of the year where we are right now, and finding your way and finding your breath and doing some abdominal, big stomach breaths makes all the difference in the world. I mean, it just calms you and gets you to a place where you feel like you can tolerate or handle what's going on around you. So breathing is everything. And so I was going to say just breathe, but I didn't do it on here. But I usually put one of those captions on here. It's super, super important to find breath, you know.
Well, I've been told that with the autonomic system and breathing, it's actually the exhale that is when we relax. And so we tend to focus on that deep breath in, but really focusing on exhaling can be
slowly as well.
Yeah.
Slow exhale. Because exhaling actually gives you relief. Like you go, oh, just exhale, you're going to be fine. You're holding your breath. Oh my gosh, it feels so much better kind of idea. So yes, absolutely. I agree.
Great,
sure.
Great. Well, let's see. I think let me go back and look at our list of questions.
I got a question.
Oh, good.
Just, it seems somebody's asking if the medication has to be taken in equal intervals or if it can be taken in different intervals.
Okay, so usually with your doctor, we'll get you to a space where you are in a good place. That's why the journals are also important. Usually you want to take it on a regular basis the way your body is actually needing it. And so we find that happy medium usually by just trial and error, actually, because it depends on how your body's going to deal with medication and how well independently and individually you're going to do well on medication, lower or higher. But usually you want to stay focused and stay constant on it so you can really get a good idea, because if you don't do that when you're journaling, it will be all over the place. because you won't have a clear line of how well the medication does if you do it regularly.
Mm-hmm. Mm-hmm.
Okay.
Yeah, that's a good point.
We have one question too, about a comment. I take cinnamon. Does it matter whether I take it with or without food, particularly protein?
Wow, let me help you. So that medication is extremely important to take without food. If you have to take it because you have nausea, then yes, you can have a carb. What that means is, let me give you a little bit of a quick overview of your GI system. So when you take carbidopa-levodopa or Sinemet, that medication is metabolized in a place called the duodenum. The duodenum is your small intestine. It is the same place your food is metabolized. So what happens is you eat food and you also take your medication at the same time. What's happening is it's a competition between the food and the medication. Guess who's going to win? Your food. And you're just going to have a very expensive stool, okay? Because that's where the medication is going to be. And so if you have to take something because you're nauseated, which can happen with carbidopa-levodopa, then take a carb, whether it be a piece of fruit, a piece of bread, some saltine crackers, because that metabolizes so fast. But if you take it with protein, which can take a long time to metabolize, especially depending on how well your gut is working at that time, and fat takes a little bit longer to metabolize. So you're not going to get the benefit, the full benefit of your medication if you take it with food. So the goal is to take it first 30 minutes away before and after meal. Whatever you decide to do, you eat, oh, I forgot, you wait a half an hour and then you take your medication. Or if you go, okay, I'm going to take my medication, okay, I'm going to wait a half an hour and then take the food. So it depends on that. If you notice that you're like, I'm still not having a robust response to my medication, then you may have to make the timing a little bit more. Some people do an hour before and after, but I always want to do it the best possibility with the least, I don't want to mess with your timing of your life. And so if I can find a way to have the best quality of medication kick in, but without having to like time your life so much around that medication is really important. That's why we look at that as well when we talk to you to make sure that, okay, 8, 12, 4, and 8, that's when I want you to take your medication. Again, that can be different for every single person. But what if every day you eat at 8, 12, 4, and 8? That would be really sad. And so I don't want to do that to you. So we find ways to actually work for you, but I really don't want you to take the medication with food if you can. But again, you can have carbs if you need to.
Okay.
Hey.
Have any more, Rachel, that you can see? Any questions?
I don't have any more questions, but I do want to make a mention that if anybody wants to save the chat with a couple of the details and information that's been given along the way, there's 3 buttons at the bottom of the chat screen that says more, and there's a button that you can save the chat, okay, and you can save that on your own. And like I mentioned in the chat, this has been recorded and will be available in the next couple of days through our YouTube channel. So feel free to check on the YouTube channel in a couple of days, or email info@pmdalliance.org and we'll send it to you. Looks like one last question. Is there a relationship between prolonged postnasal drip and Parkinson's?
No. Okay, so let me talk to you about that. I'll go a little bit further into that. So postnasal drip can happen. So there's a relationship of excessive your eyes can be, it's called lacrimation, too much tears, nasal drip from here that can create it. Ultimately that can happen, but having postnasal drip and that causes Parkinson's, no, okay? But it can be a sign or symptom of Parkinson's disease.
Thank you.
Okay, thank you. Everybody, we've got 1 minute left. So we want to thank Dr. Bixby for the time that she spent with us. So if you're on video, put yourself on video and let's wave goodbye. Have a good rest of your day, everybody. Thanks so much for this call. We appreciate it.
Thanks so much, everybody. We'll see you again soon.
See you soon. Have a good rest of your day.
Bye-bye.
Bye.
Waiting.
Waiting, waiting, waiting. Bye, everybody.
We may have to just shut it down.
I will. All right. Judy, goodbye.
Bye, Rachel. Talk
See
to
ya.
you. Bye.